my name is Dave Frumberg. I'm an assistant professor at Yale University, specializing in limb reconstruction and neuromuscular disorders. I'm here to talk to you about using external fixation, specifically circular external fixation, in the treatment of Pilon fractures, so complex distal tibia fractures, and their complications. These are my disclosures. Just a little bit about me. I'm located at Yale University, which you can see here on this map is sort of between New York City and Boston, and zoomed in there just so that you could see. Boston is up here where Harvard is, New York City down here, and somewhere in the middle is Yale. Tonight, we're going to talk about Pilon fractures very briefly, as well as their fixation strategies, and then the usage of frames. And when I say frames tonight, I'm going to really be talking about circular external fixators, so Ilizarov and Ilizarov-like fixation, and some of the different purposes and the ways that I use frames in the treatment of Pilon fractures, but most specifically for their complications. I'll give some case examples just to show some of the things that I've done and why I think that this is a versatile treatment method that is applicable all around the world. So a little bit about Pilon fractures. Not to go into too much depth, but basically there are two variants of Pilon fracture. The first being a low energy twisting type injury. So there's somewhere between, like an ankle fracture and a severe Pilon fracture, which would be the next type. So these are the lower energy kind of twisting. Think of someone who's wearing a ski boot or a rigid shoe, and they twist and they get kind of a complicated spiral type fracture. These are low risk for a severe soft tissue injury, low risk for opening. It looks something like this. So here's a nice example of one of these low energy Pilon fractures. As opposed to the violent impact type of axial load injury, which is much higher energy. So if you think of someone falling from a height, these have very high risk for severe soft tissue injury. So they're very frequently, they're open. They get a lot of swelling, a lot of blistering, which risks their infection when it comes to treat them. It's never really just a true axial load. It's usually axial plus valgus or axial plus varus, and you can get tension-sided failures of the fibula. But basically, these are much harder injuries to treat and much more cumbersome for the patient. The AO classification, I feel, is very useful in the way that I look at Pilon fractures. So I'm not a traditionally trained orthopedic traumatologist, so I stop at A, B, and C. But you can go much further, where group A is completely extra-articular. So the articular block is not necessarily involved in the need for reconstruction. Whereas at group B, there's a partial fracture, and group C, the articular segment is completely disrupted. And here's an example of a group A, where you can see the fracture is entirely extra-articular. The articular block is intact. A group B, where there is an extension down into the joint, and a group C, where the articular block is completely disrupted. The problem with Pilon fractures, and this is a classic paper from JBJS in 2003 by Pollock et al., which really showed that after these high energy plafond type Pilon type plafond fractures, what you can see here is that the SF-36 physical function scores are really not very good. So if you could see, it's a devastating injury. If you compare that to congestive heart failure, spinal injury, being on dialysis, multiple traumas, diabetes, there's a tremendous disease burden that comes along with having a Pilon fracture, which leads us to wonder, what is the best way to treat them? So if the outcomes are very poor, there's got to be some better way to do it or some worse way to do it. So I think it's very important in talks like this to understand goals. There's a lot of different ways to treat orthopedic injuries, but in the end, we really like to restore normal alignment. And when we're talking about reconstructing Pilon fractures here, we really want to talk about the distal tibia articular surface. So on an X-ray, these are really the two measurements that you have to keep in mind. So these are the from Sinai Hospital, Baltimore. These are kind of classic limb alignment views that we like to use, showing the modified mechanical axis in the sagittal plane, where the anterior distal tibia angle would be 80 degrees, or roughly 10 degrees of anterior opening. You could think of it that way, or 10 extra degrees anteriorly to prevent the talus from impinging when the patient goes into dorsiflexion. So you can imagine that if the ADTA was above 90 degrees, there would be anterior impingement. If it's too high, so above 80 degrees, then the talus may be unstable, sliding out the front. Whereas in the coronal plane, there's also the lateral distal tibia angle, which approximates 90 degrees. And so for that reason, we like to not be in a lot of valgus or a lot of varus. And obviously there's axial plane deformity as well, but we'll focus on these today. The injury radiograph is very important because it dictates the force that you must counter. So if you are using an open approach in a pilon fracture, you would typically put a plate on the concavity. It's much easier to kind of push it. Maybe picture your plate being fixed to the diaphysis, and the rest of the plate is going to push against the deforming force. So if you look at the first one, varus, that's something we would probably consider putting a plate on medially to counter that medial varus escape. Whereas the valgus failure, we would probably put a plate on laterally. Axial load, you got to put weights everywhere. But you can go a little bit further. I mean, if you look at this, I'll go through this slowly so you can think about it in your head. So starting from the left and going to the right, the first one, if we evaluate that, that's varus. So how would you plate that? Oh, I'm sorry. So you'd probably plate this one on the medial side. Whereas the second one, you'd probably consider plating it on the lateral side. This one here looks like it comes out the front. So you'd think about anterior fixation. Whereas this last one all the way on the right side, it looks like it's unstable with the talus moving posteriorly. So you would look for a dorsal approach or a dorsal fixation here on the back of the tibia. So this is I'm going to go through some studies here. This is sort of a classic one in clinical orthopedics and related research from '93, Tini and Wiss, which showed from 60 patients that had primary ORIF, half of them had a major complication. That was either major skin problems, wound dehiscence, infection, non-union, malunion, or implant failure. And so, man, 50%, if you do a surgery and there's a 50% success rate, that's probably not so good. But if there's a 50% failure rate and you're between a rock and a hard place, you may think twice about primary ORIF. But that led people to really start thinking. So it led to this idea that you could do a staged protocol. And here's a study from 1999, kind of classic paper by Sirkin in the Journal of Orthopedic Trauma, which showed that if you did a fibula ORIF, you brought the fibula out to length, and then you just did a uniplanar external fixator, so kind of a pin to bar or a delta frame construct, and you allowed the soft tissues to relax and the swelling to go down and the blisters to recede, then you did ORIF, you could greatly improve your outcomes as far as skin and wound. There are some problems with this approach that were later found, like if your fibula is not perfect, then it actually makes it much harder to fix your tibia. So it's important to get your fibula not just out to the length, but also in appropriate alignment. One strategy, which was also published in Core in 2014 by Doug Beeman from Portland, basically shows that if you have a non-reconstructable ankle after a severe injury, actually a primary arthrodesis may be a good way to go. We certainly know this in the low demand patient, but certainly something that could reduce morbidity associated with the injury going forward. So here's a nice case example or a series of examples from their paper. So we'll talk a little bit about using multiplanar external fixation, meaning the Lazarov frames. This is not something that's new. I mean, this is from Core in 1996, McDonald et al. Published this, and it's a nice little sawbones demonstration of how you can use olive wires to capture and compress segments. You can pull on deforming segments and really stay out of the zone of injury with major incisions. And in many cases, you may not even need an incision for some fracture patterns. Then there are several studies that were published in the 2000s showing that if you were to just put on a frame to get the global alignment and maybe make a small incision, manipulate fragments and stuff in some graft, such as this paper from Lung et al. An injury, then you can have excellent outcomes. I mean, so if you have a type A fracture, which is basically the articular surface is not involved, or it's spared, we should say. So you may have a metaphyseal defect, such as seen here in this middle X-ray, this middle image. Then grafting that could help, and you can end up with something similar to what we see on the right. The most common problem always is going to be pin tract infection, and there are different. We could talk about strategies to prevent and treat pin infections, but universally, if you're going to have something sticking out of your skin for 4 to 6 months, you're likely to get a superficial infection, which sometimes is just colonization and is not really too big of a problem, but it can lead to loosening and other problems. So, 30% of these patients do get a pin tract infection. In the type C fracture treated in this regard, or treated with this method, only 38% had a good outcome. So it's kind of important to know. So then here's another paper showing that if you were to use capsular ligamentotaxis, so really put a ring at the top, kind of mid shaft in the tibia, and put a ring at the bottom and pull and just get whatever alignment you could get, then again, you can get fair, good, or excellent results in most of your patients. So basically 3 out of 17 had poor results. 4 malunions, most likely angular, and 9 out of 17 pin tract infections. So we kind of expect that. Here's another paper that I thought was pretty good. 39 patients with an average fixator time of 16 weeks. So it's anywhere from 11 to 30 weeks. 5 out of 39 had poor radiographic results. And then this is a nice paper from STLR in 2009, using ligamentotaxis and then making a small incision such as seen here and just kind of manipulating the major fragments into place is very helpful. So here's a picture of a really severe type C pilon fracture. I mean, it's hard to even know, is it, so this is like an AP maybe of the leg, and then the ankle is nowhere near where it's supposed to be, and it looks like this is a oblique of the talus. So this is just a sort of a shattered ankle. But if you just pull on it and using intramedullary fixation for the fibula just to help assist with the length stability, you can see you get a pretty reasonable alignment. And then with making a small incision away from, really sort of at the edge of the zone of injury, so not over the ankle, you can see here they have a clamp on the inside that looks like a Coker clamp, and they're manipulating fragments directly. And using that, the other thing that was nice about this paper is this technique is they show olive wires being used to compress different fragments and pull fragments into alignment. And then if you look at this quality of life, this study had a lot of different things in it, but I think the two things that I like to point out are that quality of life measures tend to improve during treatment. So the longer the fixator is on, patients' quality of life gets better. That kind of makes sense, because the point of using a fixator is that you can have functional use of the limb and everything stays stable. Well, that's great, but as you start feeling better, your swelling subsides, you start to heal and make secondary bone healing, and you are less painful, then you'll use your leg more, and most likely your quality of life will improve as you get to use the fixator to your advantage and really have less pain and whatnot. And then the other thing is that was demonstrated in this paper that there is a significant depression rate. This is a psychological study or a psychological measure, not a joint depression rate, but a psychological depression rate 8 weeks after frame removal. So while patients have improving quality of life, their treatment from their injury will not end once you declare they are radiographically healed. So that's what I took away from that. So my strategy when I am looking at pilon fractures is, number one, the most important thing, any fracture management, is the soft tissue injury. Is it compromised now? Meaning, is it open? Does it need an immediate graft? Is there something I can do to assist with the closure? Is it a high likelihood to be compromised soon? Or is it highly likely to be compromised later? Meaning, like this what you see on the right side here, this high energy mechanism with significant bruising, if you look at the Cherney classification of soft tissue injury, I mean, this would be pretty much all the way to the right. So is it going to be compromised now? Is it compromised now, or is it going to be compromised later? That's what I really want to know. If I make an incision on this, am I getting myself into trouble? Number two, I want to determine the intra-articular injury. So is it reconstructible or is it not reconstructible? Meaning, can I take the articular surface and put it back together? Is the articular injury a type B or a type C? And if it's a type B, meaning a partial articular, can I convert that to a type A? So can I maybe put some fixation on at the plafond and put the articular surface back together and then just pretend that fracture line doesn't exist and then go on to put that whole articular block back on the tibia? That's probably the best strategy. If it's a type C, I may be able to get away with that if I can do a little bit more fixation or kind of smaller amount of fixation. So here, for example, this injury here doesn't look too bad. This is an axial load injury after a dirt bike crash, but you can see the overall alignment is pretty good. When you look at the CT, you can see pretty significant joint disruption, but this is something that most likely you could reconstruct. So if you look at this sagittal plane CT here on the bottom right, you can definitely get a lag screw or a position screw across this fracture line. And then this fracture line is definitely reconstructible. So you can most likely convert this pretty complicated fracture segment into a type A fracture with minimal fixation. In fact, that's actually what the surgeon did here. And that's useful because once you figure out what the intra-articular injury is, you can look extra-articularly and try to figure out, if I make an articular block, do I have enough left that when I put that articular block along the tibia at its appropriate alignment, will I get this thing to heal? So what is the likelihood of success with primary versus secondary bone healing? In this case, this may actually be primary bone healing if this can be compressed enough, because there's enough bone stock remaining. If you have a huge bone void, it may require grafting. It may need some help to heal with secondary bone healing, meaning formation of callus that eventually converts to bone. The other thing that's really important is if you determine that you're going to need an open approach or some assist with open surgery, you really need to understand where the potential incisions may be. So for example, if you think that your tibia had a valgus failure, but you want to plate the fibula to get it out to length, you better remember that you might be approaching this anterolaterally, and your fibula incision better not compromise your skin bridge between your anterolateral incision and your fibula incision. So things like that need to be really thought out. Okay, this is the master, Professor Ilazarov. He is why we are here to talk. I'm going to go through now some cases and some scenarios where I have used circular external fixator to treat pilon fractures, and why I believe it is something that you should have in your armamentarium. This is a case of a 31-year-old. It's a snowboarding injury, so his legs were locked into boots together, and he twisted, and he sustained this injury. It is closed. If we look at it, we know it's a twisting injury, and we know that's a low-energy pilon fracture, and so it is unlikely to have skin compromise that is severe, or less likely, I should say. If you look at the x-rays, you'll see here an AP moving to the right on the left side, and a mortise view, which demonstrate that the articular segment appears to be mostly intact. The architecture here can be determined pretty easily. And in the lateral, there's a big metaphyseal extra-articular fracture comminution. If we look at his CT scan, you'd probably call this a type B fracture. Anteriorly, the Chaput tubercle is off, but it looks like on the sagittal plane, you can see that it is not well aligned. The tibia is not out at length either. So this is a nice example of a fracture that is a type B that you could easily, maybe not easily, but you can definitely convert it to a type A. And so again, looking at the CT 3D rendering, this might be just easier for you to see. It's a pretty complicated fracture, but this articular segment is what we're most worried about. So my strategy here was to do just that, to try to convert it to a type A fracture. So ignoring everything else, this articular segment gets treated with limited open reduction. So, probably a 1.5 centimeter incision, and then a counter incision just to get my clamp. And with the pointed reduction clamp, just manipulating it as well as I can, and then putting in a single screw with a washer. And now that fracture fragment is nicely fixed. And so I can go on to the next phase, which is applying a circular external fixator. Now, if you look at this, you can see that I've restored the overall coronal alignment and length very nicely, but I am translated anteriorly. That can be very difficult to see radiographically and also clinically. So you always have to train yourself to use surrogates. In this case, I like to use the body of the talus because I usually know where that is. And I can also see the center of the subtalar joint pretty reliably. So with those things, I try to align that as the center of the sagittal mechanical axis. So here I can clearly see that the foot is anteriorly translated in relation to the rest of the tibia. Now, this is a hexapod circular external fixator. That, if you have that available, that is very useful because you can change the alignment later, and that's exactly what I do. So I'll take these x-rays. These are intra-op x-rays, but typically I would just get x-rays in the clinic, and then I can move things how I need them. Here is the 3-week follow-up, and at this point, I've started to manipulate the fracture to try to get the talus back under the tibia, and you can see he's functionally weight-bearing on this. You can see the very small anterolateral incision that I used. By 3 months, he's flying away to Hawaii for a business trip. He's using his limb functionally. He sent me these photos and told me I can use them in every talk I ever give, and I absolutely will. And really pain-free, loving life. At 4 months, which is typically how long I leave the frame on, we can see that the ring is tipped to the side because it required that in order to get my alignment perfect, which is okay. But you can see union of the fractures. At this point, he gets his frame off, and this is his 1-year follow-up demonstrating really what I would consider perfect healing. So this is a really nice strategy for a type B fracture. This is an 11-year-old boy who jumped out of a second floor height. He has a Salter-Harris type 5 fracture of his tibia and of his fibula, and this is a Gastillo-Anderson type 3A open fracture. So here what we're looking at is physis. This can be managed multiple different ways. Actually had the goal here of trying to save his physis, even though that's a little bit of a fool's errand. But again, you have a lot of comminution and a lot of gross contamination. Treat the soft tissue first. So in this case, put him in a frame. I put this is a large Steinman pin kind of up his fibula just to head those Salter-Harris 1 and metadiaphyseal fracture lines, kind of like shish kebab it together. And then by pulling traction with the frame, I was able to use whatever ligamentotaxis I could to align this fracture. And his physis looks like it's in reasonable alignment. He definitely is tipping into valgus. He was in the frame for 8 weeks, and then I took it off, and this is his 12-week x-ray, and it's really hard to know if this physis is going to survive, but you can see union at all the fracture sites. This is 3.5 years out. You can see that at some point I put a hemiepiphysiodesis screw in his medial malleolus just to prevent him from tipping into further valgus. And it looks like he has a reasonable alignment. He's actually playing basketball at a very high level. So this was what I would call a success, but we knew that the articular surface and the physis were probably doomed at the time of injury. But just simple frame with distraction and realigning the fibula have gotten us what I consider an acceptable result. Okay, what about just adding a frame? So a lot of times the strategy would be, I'm going to do something to the foot or the ankle, and I'm just going to add a frame to improve the stability. A lot of times people will do that. Let's say they're doing an ankle fusion, and they'll just add a frame for added stability. We know that a frame can give you significant axial plane stability. It can convert all your shear forces into pure compression, so it's very good. Well, here's a nice case of a 15-year-old. He has autism spectrum disorder, and he went to leave his second floor window and ended up with this injury. So this is an axial load with valgus force. So you can see that the talus pushed the plafond up and medially. And this is a pretty complicated injury, but one thing that's really nice about kids is that they really tend to have good ligamentotaxis. So in this case, when we look at his plafond, we can see that this is a type C injury. It has complete articular involvement. But on the coronal, it looks like this lines up pretty nicely. And on the sagittal, it looks like this line, this coronal fracture lines up pretty nicely on the sagittal plane. His extra articular fracture looks like it would be a type B fracture where I could buttress that down or put an anti-glide plate on. So there's a lot of swelling in these injuries initially, but through a very small incision, I'll show you on the next film, I can make a really reasonable approach to try to just put a buttress plate on, and then I can plate his fibula out to length. And so this is what it looks like after I add a frame for added stability, because this is a patient that will probably not follow non-weight-bearing instructions. In fact, his parents told me he's not going to follow that. He's going to walk on whatever you do. So in this case, I have very minimal fixation. I made an incision that's about the distance between these two screws and simply slid a 1/3 tubular plate down and just put 2 screws in to control that. And that is buttressing that entire articular segment down. Plating the fibula out to length, plus adding a frame for added stability, allowed this child to walk on this for the entire duration of treatment. Here's an image of the frame, and you can see really how small that incision is. And this is him at 2 weeks, walking on it in the office, maintaining his alignment. And after 6 weeks, he has really nice healing, and I removed the frame at that time. And these are his 12-week x-rays, which demonstrate union. Whenever you put a frame across an ankle, you'll always get osteopenia, even if they're using it as much as they can, just because the forces are kind of bypassing the bone. So if you ever capture an ankle in a frame, it will always appear osteopenic after a few months. And that's certainly what we see here, but more importantly, we see union of the fracture. And here's an 8-month film showing maturity of all his bone healing. So now we're going to talk about frames for complications. So typically when people think of complications in pilons, they think of infection, which is very high complication, or they'll think of non-unions. You may also have malunions. You could have bone defects. Arthritis is a big one, but we probably won't talk about that here. So here's the first complication we're going to talk about is loss of fixation. This does happen. In my practice, it tends to happen the most when people are non-compliant with their weight-bearing restrictions. Here's one example, a 64-year-old woman with a closed pilon fracture. So you can see this is an entirely extra-articular injury. It's a type A fracture. This is one that you could treat primarily with an external fixator. My partner opted to treat this with ORIF. So here are the fluoro shots, where you can see a posterior approach was made, the fibula was plated, and the tibia was brought out to length and really nicely anatomically aligned. And then at her 8-week follow-up, at her first post-op x-rays, she told us that she told my partner that she was walking on it the entire time. And then look what happens. So we have loss of fixation, broken screws, shortening of the fracture, bad news. So in that case, we returned to the operating room, we removed the hardware, and I applied this frame. So this is it looks like a lot. It's a big spanning frame. So we have a ring block on the proximal segment. We know this patient's going to walk on it the entire time. And then we have the foot captured and the distal tibia. Whenever you have to do the distal tibia, I always include the foot, always, because this is a really, really small segment. And even if you can get 4 wires in it, it's just not enough to counter the lever arm of the rest of the body. So usually link that down to the foot and include that. And I'm using a hexapod here in case she has some late displacement that I need to correct. But certainly, if you have access to Ilizarov hinges, you could also place those in the office. or you can place a static frame as well and just be prepared to manipulate it as you need it. This is when the hardware, I'm sorry, this is just more clinical pictures showing the sagittal plane. And then, so these are 8-week x-rays, which demonstrate some healing. And if we zoomed in, we would be able to see that there's some nice callus formation. And then I removed the frame at 12 weeks, which is a little bit earlier than typical, but she was healed. Now at 5 months, these are her x-rays. And you can see here some just nice callus formation and full healing. And again, what I was talking about with the osteopenia, which you always get when you span. Here's 10 months, x-ray show maturation of the healing, and obviously plantigrade and walking. Okay, another complication is non-union. We see this very frequently. This is a 51-year-old man who had ORIF, so open reduction and plating of his fibula, and a unilateral X-fix a year ago. The problem is that no one ever told him to stop smoking. So he has a non-union that's painful, and he hasn't been able to return to work. He saw my partner who said, quit smoking if you want us to fix your leg. And he did. He actually did. So now he's 2 months out from quitting smoking. His nutrition is excellent, and he wants this non-union fixed. So the first step that I do, and I apologize, I don't have these images, but I will do, if I feel that maybe there is gross instability, I'll do a stress x-ray, and his stress x-ray certainly showed that he had some valgus instability at the fracture site. So I could actually gap it open. This is one that if you have access to pre-planning with hexapods, this works very nicely. So in this case, I know what my deformity is. So if I plan my rings ahead of time, then I can pre-build my frame and then sterilize it. And then when I get into the operating room, just slide it on the patient and go. This is what our plan looked like preoperatively. And so this is what the surgery looks like through a small medial approach. I took an osteotome and placed it across. This was a true pseudoarthrosis. So cleaned out all that tissue and got this mobile again. And in this case, I think I didn't like the way that the pre-built frame appeared. And so I just placed the ring first. So here you can see multiple wires just fixing the articular segment. And then it becomes sort of like an A-type fracture that we were discussing before, where we just need the extra articular segment to heal. So post-operatively, this is his alignment, which is acceptable for sure. Remember that he's missing a segment of his metaphysis. So the x-rays are never going to look totally normal, because if you have a trapezoid of a bone and you cut out a segment of it, when you compress the two back together, you're going to have a mismatch. So the malleolus looks like it's jutting out a little bit more, but that's okay. The best way to get this thing to heal is to compress it. And that's exactly what I do here with this 6-axis frame. I think Ilazarov said you can squeeze infections out of bone. So hopefully we can squeeze a non-union out of the bone and just get primary bone healing. 14 weeks in the frame, he's starting to make callus. Typically, I would get a CT scan at this point if I'm thinking about removing the frame. But for him, it was very obvious that his frame, that his fracture had healed. So I removed his frame at 16 weeks. And here's his 5-month x-rays demonstrating union. And he returned to work, actually. And here's 12-month x-rays recently. And this is what I was trying to say before. So as long as your alignment is good, you can see how much I compressed him to get this to heal, that this segment of the tibia is just over. There's an intussusception of the metadiaphysis into the epiphysis. So that's why it appears to be this way. Okay, the next one is a deficient articular segment. Now, this may not necessarily be a complication so much as it's a treatment problem that we encounter. In this case, this is a 40-year-old who fell into a large ditch and had a type 3A open pilon fracture that you can see 17 weeks ago. Before he got to me, he was debrided and he was placed, this is a cement spacer here. So he was debrided and placed in an external fixator. And then 14 weeks later, he had his external fixator removed. The surgeon attempted to fix the articular segment and then put him in a big cement spacer here, and then put him in a splint and sent him to me. So now his wound has been closed and healed for 3 weeks, and this is what he looks like. So he's First of all, very osteopenic. You can see that. But also, this is really not a viable articular surface. So at this point, got a CT scan, which demonstrated that actually the cartilage surface did not really have much height. So it's hard to show that. And I don't know if that means as much as his fractures were not uniting. And there's probably limited blood supply here due to the severity of the injury. So here you don't really have an articular segment. So what can you really do? In this case, opted to do an arthrodesis. And it's not a primary arthrodesis because he's already had 2 surgeries. So this is what his leg looks like. The skin looks good. I mean, it's swollen, you know, and a little bit crooked, but that's a really nice skin envelope. So what I did was I took the spacer out. The plafond, the tibial plafond fell right out. You can see I left the fibula in just in case I needed to either do a cross union to assist in my fusion later, or if I needed to move the fibula over in a free tissue transfer. I usually like to leave it undisturbed if I don't need to bother it. A frame was mounted here with cables passing around pulleys that go inside the skin. As you can see here, the cable is tied to the end of the bone. There's a 67 millimeter defect. Now, the talus was prepared, and that's very important. Cartilage tends to harbor bacteria, so you wouldn't keep the cartilage on the talus after this surgery. You would want to take it all out, especially since you'll get the best look at it now. And then you can see a corticotomy made proximally to initiate bone segment transport. This is called the Weber cable technique, where you would use cables inline around a fulcrum that's past where the goal is so that you can continue to pull compression at the end of treatment. And so here's what it looks like fully in the frame, and here's him walking in the frame. And just to go back, I'll show you, here's the cable exiting the skin. And I'm sorry, here's the cable exiting the skin and rotating around the pulley up to these clickers. So he will click upward, pull the cable up, which around the pulley will pull the bone segment down. And as he does that, you can see the segment moves down, and then he's almost there at station. And at that point, I would take him back to the operating room. I added a pin to his talus, you can see, to give me more pressure. And then I added bone graft in there as a formal docking procedure. And then after I took his frame off at 9.5 months, he actually tripped and fell and bent his regenerate. Poor guy, but he's okay. And his overall alignment is pretty good. He's a little bit short on that side, as they typically are. He's opting not to pursue a lengthening or any further surgery. He has a successful arthrodesis, and he's returned to work with a shoe lift. Another complication is infection. It happens all the time. Here's a 74-year-old man that was transferred from an outside hospital, type 3 open pilon. They put an X-fix on it and debrided it, but didn't do any other skin coverage. So he was sort of doomed from the start. You really want to get the skin covered within a couple of days. So my partner took him and cleaned it out again and revised his external fixator to improve his alignment. But you can see here, there's a nasty articular injury, and the extra-articular injury is pretty, or the extra-articular segment is pretty deficient. So this is what frequently happens. He gets 3 plates to add to his burden of injury. The alignment is perfect. Everyone high fives. He gets a skin graft, and we wait. Well, unfortunately, 3 weeks out, everything is holding. It looks pretty good. But again, this older gentleman with really damaged blood supply, this may not hold. 4 months after his ORIF, he had drainage from under his flap and increasing pain. The plastic surgeon took him and washed it out, found pus, and this grew a gram-positive anaerobe. So he started treatment there. And then ultimately, he had fixation failure. So all of this is infected. My partner then took him to the operating room to explore this and found that all of it was necrotic. So this is 5 months post-ORIF. My partner did irrigation and debridement. He took out all of the plates. He excised all the bone until it looked healthy, which ended up being a 100 millimeter defect. At that point, he knew what I would be doing when he sent it to me. And so he prepared the talus. And again, I can't stress enough how important that is. Get the cartilage out because it harbors bacteria. And then this is an antibiotic cement spacer, and he's in a splint. So now we have this defect that we have to reconstruct. So for me, the most important thing is going to be the soft tissues. So I need his soft tissues to rest. I need the swelling to go down, and I need them to be apposable. So I don't want any problems with his skin graft. So I did a spacer exchange and washed it out, made sure it was clean, and mounted a frame, allowed him to get good antibiotic treatment. And then we take him back to transport. So in this case, I did another cable transport, but instead of using just the wires exiting through the skin, in order to protect his flap, I placed a wire through the Achilles tendon and out the front of his tibia, which you can see here. And I'm going to use that tensioned wire as a fulcrum. So here you can see the cables are mounted around the tibia. These are antibiotic loaded calcium sulfate beads that I placed in the defect. And then these cables will go around the wire and out to these clickers. So these are special clickers here. And then he will start transporting. And you can see here, initiation of transport. And as he's going, the segment is moving distally, and the defect is closing, and the regenerating gap is growing. And then unfortunately, at this point, if you look here, he starts to be unable to continue transport. So this older gentleman had what's called a premature consolidation. So I had to actually cut him again. And we typically don't like to cut through the regenerate. It's really hard to do. So we always like to cut it at a new place. I felt that if I cut here in the metaphysis, which is recommended, it was too close to this pin site. So I didn't really leave myself enough real estate there. So I cut him again, and then he continued his transport until he was apposed distally, at which point he was basically ready to come back, but he came back about a week too soon. After 4 months of transport, he had some pain and erythema here. So the plastic surgeon felt that he had a persistent infection under his flap. So his dead space was contaminated, but we continued transport because you could squeeze the infection out of a bone. So after 21 weeks of transport, 147 days, he gains 100 millimeters for an average of about 15 days per centimeter, which is a pretty reasonable average. And at that point, I felt that this regenerate was not strong enough to support itself. I learned my lesson from the other guy. So I put in a percutaneous locking plate just to hold the alignment and help stiffen the construct, which we like to call active stiffening, which actually helps the regenerate consolidate. And then I placed a tibiotalo-calcaneal fusion nail. And I was very careful not to overlap these, even though it causes a stress riser here distally, just in case it was infected. I wanted in case the dead space infection persisted, I wanted to make sure that it didn't result in contaminating the rest of the tibia. So I tried to keep these biologically separate. And this is dynamically locked. So 4 months out of the frame, you can see what his soft tissues look like. They're nicely healed. He does have a quite large edematous flap, but all signs show that he's infection-free. And this is where we are now. All right, another complication would be contracture. This actually happens much more commonly than I think we admit. This was a little bit of a sad story. As a 36-year-old man with diabetes and a hemoglobin A1C of 10, so really not perfectly controlled. He had a polytraumatic injury. I believe he was a motorcyclist. He also had a closed head injury that resulted in him losing his hearing, so pretty severe. He had distal tibia type B fracture, and then he also had a distal fibula fracture that was treated as simply as possible because of his diabetes. And unfortunately, it happened during the pandemic. So he had many other injuries too. So his other leg was injured, his arm was injured. He had rib and abdominal injuries, and I think also a pelvic injury. So ultimately, he went to a rehab facility, and due to the pandemic, they sort of left him in bed. And if you just lay in bed, everyone knows you end up with an equinus contracture. That's exactly what happened to him. And the problem with a 60-degree equinus contracture is that it's really hard to rehab after that. So here's a clinical photo after I took him to the operating room and removed his hardware to reopen his incision. Now, your options here are a gradual correction or an acute correction. If you do an acute correction, that involves an Achilles lengthening and probably a subtalar joint and posterior ankle capsulotomy. And you may also need to lengthen a lot more stuff, which is dangerous. We know that when we do that in very little kids, a lot of times we can't even close the incision but you can't do that in an adult diabetic person. So rather than make a lot of incisions, I have opted to treat this with an external fixation and no incisions aside from pins. So I removed his hardware and then mounted a frame. So you can see here basically how this happens. This is a traditional Ilazarov hinge frame. And the way you would do it is mount your ring block. This does not have to be in line with the tibia. I just think it helps with figuring out if you have to move the hinges later, where they should go. So in this case, we can see that the ring block was mounted parallel to the tibia. And then the way you find your axis for the hinges is called the Inman axis. So it would be from the tip of one malleolus to the tip of the other malleolus. And the reason for that is that the ankle is not just a simple hinge. We know that there's a little bit of rotation, inversion, eversion, inversion, eversion, and rotation. So not just dorsiflexion, plantar flexion. So that is your true axis, and you can put cannulated hinges over that and then mount them to your frame. And then very importantly, distract proximally to move the talus away from the tibia, just to ensure you don't have any impingement in case you're off just a little bit. So the frame gets mounted to the foot, the frame gets mounted to the tibia, and then traditionally you would place the hinge posteriorly because hinges do better when they're pushing rather than pulling. But this gentleman, unfortunately, because of his closed head injury, it was easier for him to try to understand by looking at it. So I placed the hinge anteriorly and let him shorten it. Eventually, I did move it to the other side, as you can see here. So here's 1 month into correction. You can see he's coming out nicely. He's needs to be distracted a little bit more. But then I moved the hinges to the back, as you can see. And then at 12 weeks, he's past neutral. I try to go 20 degrees past neutral. But the other thing you can see is that his toes, which you have an option to pin toes so that you also will stretch the flexors of the digits. In this case, I didn't do that because he previously had that done and he really didn't like the experience. You know, in hindsight, probably should have. Very important, by the way, this post is the wire that's the talus that's making sure that you're pushing through the talus and distracting through the talus. So I should have mentioned that before. Make sure you have a talus wire. At 16 weeks, so I get him to the target, which is I try to do 20 degrees of dorsiflexion. And then I let him sit there for 4 weeks. This is what I typically do. And then I'll take him to the operating room, remove the frame. So this is after I removed it and washed his leg. And then he has residual flexion contractures of his toes, which I'll do simple percutaneous tenotomies. I try not to do the FHL because I think it's important for walking, but the lesser toes, I will definitely do an FDL tenotomy. 9 months after frame removal, he's maintaining plantigrade and very happy. So that's pretty much all I got. In summary, pilon fractures are devastating injuries. And we know that they're devastating not just for the surgeon, but they're definitely devastating for your patients. And even the best cases that look great on x-ray really don't always do well. And you as a surgeon have a unique opportunity to make the entire situation worse by doing the wrong thing, whether it's operating too soon and contributing to the possibility of infection or choosing the wrong fixation. There's a lot of ways that this could go south. So I personally like fixation strategies that minimize the amount of dissection because they respect the soft tissues. Also, if the alignment isn't so good or I want to compress it later, I can manipulate an external fixator with no real problem to the patient to correct alignment or to improve the axial alignment as well. And there are many uses of this versatile device. So you can use it for definitive management. You can use it when maybe you don't trust your fixation or you want to add stability, decrease shear, or maybe you have a patient that may be non-compliant and it would be better for them to be able to walk on their leg, or a patient maybe that lives independently and really needs to be able to transfer themselves, or consider the patient that was multiply injured and this is their only injury on this leg and their other leg maybe has an injury that they can't bear weight on. If you give them the ability to do so much as stand to transfer and pivot transfer, you will definitely improve their rehabilitation over the next 6 months to a year. And then obviously, complications happen a lot. These are devastating injuries. Complications happen to everybody. And I think the external fixator is very useful in the management of complications. With that, I will close. I'd like to thank you for your attention. If you have any questions or considerations for things that I'm doing differently, or if I can help you with any of your cases or frame stuff, feel free to email me. That is my Twitter address right there. But if email, I promise you, I will help you through cases. And I hope you have a great time at this conference.